Thank you so much for having me. This is always such a great conference, and it's just really such an honor to be here and to be talking to you guys today. I am going to talk about using transcutaneous CO2 monitoring in the pediatric ICU. So what I would like you guys to come out of this with is understanding the clinical value of accurate continuous CO2 monitoring. I want you to understand the different methods of CO2 monitoring and the advantages and disadvantages of those methods, and also highlight really how transcutaneous monitoring specifically can help you in your practice. Now, I am talking specifically about the pediatric ICU, but I want to challenge you, those of you who work in other care areas, to think about how this would translate into those other care areas. I mean, in fact, I like to really get an idea of how many people are working in the PICU, NICU, and adults. So how many NICU therapists do I have? One? Okay. I've got questions for you guys. Just kidding. What about PICU? A half a hand? So nobody in the PICU? Okay. That's good to know, because a lot of this stuff then isn't going to be relative to your practice. Are you guys doing adults? Is that what everybody's doing? Okay, that is so good to know. I can tailor this down so that it's going to be relative to your practice in the adult ICU. I will be referring to PICU a lot, but we will all start thinking about how this would relate to adult care. And what about students? How many students do I have? I had talked to a few yesterday. I guess they're all, okay. All right, well, good to know. I do have a disclosure slide. It didn't seem to make it in here, but I do need to disclose that I work for Syntec. We do manufacture and distribute one of the technologies for monitoring continuous CO2. There's a couple of manufacturers out there. I'm so passionate about this technology in general, so I'm going to be talking about the technology, not specifically about the brand, and I think you guys will get that. So, when we're looking at the pediatric ICU admissions, one of the things that we learn when we take PALS is that about 30% of patients who come into and have cardiac arrest are because of respiratory issues. Respiratory failure is the #1 cause of disease process beginnings in this pediatric population. Okay, one of my IT things is that these are not my notes, they're somebody else's notes. So just bear with me, I'm gonna go for it. So acute respiratory infections account for 17% of all deaths in children who are under the age of 5, and that's all children under the age of 5. So if you take out the neonatal population, that percentage actually jumps up to 26%. So a huge portion of deaths in children under 5 are from respiratory issues, and so these need to be addressed. We need to look at these very, very closely, be able to identify patients who are in respiratory distress so that it doesn't lead to respiratory failure. There's a couple of scenarios that bring our kids into the pediatric ICUs with respiratory failure, and those are going to be acute respiratory failure scenarios. So patients with pediatric acute respiratory distress syndrome, in these slides and in my presentation, I call it ARDS, but what I mean is it's not acute respiratory, or it's not adult respiratory distress, it's acute respiratory distress. So it's going to be, that term is applicable for all patient populations. Acute respiratory failure also includes patients with bronchitis, bronchiolitis, those patients who come in with croup and different type of pneumonia disease processes. Now, in our pediatric population, one of the big issues is bronchiolitis, and that is something that when pediatric patients are admitted, most of them are admitted with bronchiolitis. They also come in with chronic lung diseases, similar to your adult patient populations will come in with COPD and other chronic lung diseases. The pediatric patients come in with a lot of asthma, which we do see that in the adult population as well. They also come in with a lot of tracheal or bronchial malasias, and they've also got restrictive diseases such as cystic fibrosis, and ex-preemie populations will come in with bronchial pulmonary dysplasia or chronic lung disease as a result of being born preterm and having that damaging positive pressure ventilation when they were babies. There's also respiratory failure secondary to other disease processes such as neuromuscular disorders, neurological disorders, cardiac anomalies, which we see some in some pediatric populations, but we do see some cardiac deficiencies in adult populations as well. A surprising number of pediatric patients do come in with sleep disordered breathing, which the other group who is in our sleep track know this, and there's always post-surgical patients. So when we talk about the diseases in the pediatric patients that are most difficult to manage when they're intubated, it's going to come down to three basic things. Those kids with bronchiolitis, those patients who have full-blown ARDS, and the asthmatic patients. And what we see across these three populations is some things in common. For example, they're all going to have an inflammatory response. So inflammation of the lungs is going to cause a whole cascade of disease processes. A lot of them will have atelectasis. The bronchiolitis patients will have atelectasis from extra secretion production. The ARDS patients do have a lot of pulmonary edema because of that disease process. When you're looking at your severe asthmatic patients, they're going to have a lot of bronchospasms, and you're going to have to be dealing with that. And across the board, these patients are all hard to manage when they're intubated, because when we intubate somebody, what are we doing? We're giving them positive pressure ventilation, and that's causing lung damage. We know that. That's causing them lung damage, and that's also exposing them to the risk of worsening infections, hospital-acquired infections, or ventilated-associated pneumonias. So all of these patients, you really need to be very cognizant of how we're managing their ventilator, making sure we're using the most lung protective strategies possible. When we are managing our patients on the vents, all patients, even adults, we look at a couple of things. In fact, when you think about it, as a respiratory therapist, everything we do comes down to two things. Everything we do is for one of two reasons, either to improve oxygenation or to improve ventilation. Would y'all agree with that? It's either one of those two things, or most likely both, right? And we're always watching the oxygenation. Now that we have pulse oximeters, they're ubiquitous. Everybody gets a pulse oximeter. As y'all mentioned, I've been practicing respiratory care for 30 years. When I first started 30 years ago, when someone needed an oxygen saturation, they'd call the RT. We'd go up there with our pulse ox, we'd read their pulse oximeter, we would chart it, we'd go on about the day. Now, we don't do that. The patient care techs do that. Everybody does that. You go on Amazon and you give Jeff Bezos some money and he's going to send you a pulse oximeter, right? So we all are very aware of oxygen status and how important it is. But what's the other big thing we do as respiratory therapists? Ventilation. And how do you assess ventilation? A couple of ways. You look at their work of breathing, also you look at their CO2. But we don't really look that closely at the CO2 because it's a harder value to get. And we'll talk about that some more. But understanding a patient's CO2 level and knowing what it is on a continuous basis is really going to help you across all disease populations so that you can assess treatments, so that you can optimize non-invasive ventilation, so that you can avoid intubation. And if they are intubated, you can give them the least amount of support needed to create the least amount of lung damage, but also support their oxygenation and ventilation needs. So let's talk about non-invasive ventilation, and this is, again, specifically in the pediatric ICU, and I'm really curious to know if in the adult ICU you guys are kind of leaning towards more non-invasive ventilation as well. Used to be a patient would get admitted, let's say a sick kid comes in and we're going to give them oxygen, and we can see their oxygen status real easy so we know if they need oxygen, put them on a pulse oximeter. You've got visibility to their SpO2, heart rate, respiratory rate. You're not really going to be able to see their CO2 values unless you're doing a blood gas when they're on supplemental oxygen. So very quickly these patients would get intubated because with the pediatrics, they compensate until they don't, and it can be real quick when they flip. So a lot of times they would get intubated fairly quickly so that you can see their FiO2, you can see their pulse rate, respiratory rate, etc. But also on an intubated patient, you can get their end-tidal CO2. Do you guys do a lot of end-tidal CO2 monitoring in adults? It's very nice, right? You get that breath-to-breath waveform, you know if they're intubated, you know if they're extubated. So it's nice to have that, and when their patients are intubated, you do have that. But more and more, we're going towards non-invasive ventilation because we know being intubated means a lot of things. It means, A, you're bypassing your upper airway, which is where we have a lot of our disease resistance. So automatically when patients are intubated, ventilated-associated pneumonia pops up on our differential, right? B, you have to sedate them to intubate them. In the neonatal population, we don't sedate them when they're intubated because they don't fight. They're not as strong. They don't fight back as much. So but with adults, God, can you imagine having to intubate an adult without sedating them and even paralyzing them a lot of times? And we know that sedation is not good for patients. The other thing, the other reason why we want to avoid intubation is because what's our goal with intubation? It's extubation. Of course, you want to oxygenate and ventilate them properly, but our goal is always extubation, and you want to try to extubate them as fast as possible. We know that patients who are intubated have a longer length of stay, they have a higher cost of stay, and I've got some statistics on that a little bit later. So we're all trying to not intubate the patients. We don't want anybody intubated. We especially don't want any kids intubated. So now we're using more and more non-invasive ventilation, which is great. It's great for the patient, it's great for the length of stay, it's great for the families, but you don't have visibility to their CO2 because end-tidal doesn't really work when they're non-invasive, and again, we're going to go into that more later. So if you can somehow continuously monitor their CO2 throughout this process, if you can use transcutaneous CO2 monitoring, it's going to really help guide you and help those patients when they are being non-invasively ventilated, whether it's just a high-flow cannula or if it's CPAP or BiPAP. The other big reason to look at carbon dioxide so closely is because it's very, very closely associated with mortality rates. Both high and low CO2 levels are associated with mortality rates. So patients who have ARDS, specifically PICU patients who have ARDS, if they have normal capnia, they have a mortality rate of about 27%. But if they're hypocapnic, so if their CO2 is chronically low for long periods of time, that mortality rate goes up to 38%. So that's a pretty significant jump. Now, why would that be? Probably because when you're blowing off if you're blowing off too much CO2, you're using high ventilator pressures and you're using high tidal volumes. So this means you're probably causing more lung damage, and that may be one of the reasons why we do see an increased mortality in patients who are hypocarbic when they have ARDS. There is a lot of statistics out there saying that having a little permissive hypercapnia, letting your CO2 go up a little bit higher into the 60s and 70s, I know that makes us all uncomfortable, but as long as the pH is 7.2 or higher, we're going to allow for some of that permissive hypercarbia on a limited basis. And we do see an increase in survivability in those patients who are treated that way. And why? Because we're not damaging their lungs. We're using the minimal amount of pressure and volumes it's taking to get the job done. Severe hypercapnia is probably no surprise to us that it is associated with a higher ICU mortality rates in patients who do have ARDS. So too low CO2, too high CO2, increased mortality rates. Some normal capnia or a little bit of permissive hypercapnia, as long as your pH stays above 7.2, is going to be the way you want to go. So that means we want to watch the CO2 very, very closely. Now, this is interesting information as well. This looked at patients who were hypoxic or had hypercapnia and patients who had both, and it looked at their length of stay and their cost of stay. And what they found was that the patients who were hypercapnic alone had a longer length of stay than the patients who were hypoxic alone. The patients who had both hypercapnia and hypoxia, they had the longest length of stay of all these. So patients who were just hypoxic had about a 10-day length of stay. Hypercapnic patients, 15. If they had both, it's 21. So those length of stays also were associated with a increased cost of stay. You can see the cost of stay down here in the bottom graph. The cost of stay for the lower level is the ones who are just hypoxic. The medium one is the ones who are hypercapnic, and the largest line is the ones who are both hypoxic and hypercapnic. So what I was talking about earlier is we're looking at everybody's oxygen status. But it's super important to look at their CO2 status, because the metrics on the CO2 status indicate increased length of stay, increased cost of stay. When we talk about one of those difficult to manage intubated situations, the kids with bronchiolitis really comes up. And the incidence of bronchiolitis has increased significantly over the past decades. This looked at the years 2000 to 2020. What they found was that, and this was a huge patient population, so 15,000 plus PICU admissions. And what they found was in the early 2000s, there was a lower rate of bronchiolitis diagnosis in patients, and it's increased greatly from about 10% to up to 20%, depending on what country you're looking at. This study looked at patients from a bunch of different studies, or a bunch of different countries. So the incidence of bronchiolitis and the incidence of PICU admissions because of it has gone up. A lot of patients with bronchiolitis back in the early 2000s were admitted and they were intubated immediately. In fact, in this patient population group, this group that was studied, all of the patients who were first admitted on mechanical ventilation were admitted intubated. And right around 2003, 2004 is when the use of CPAP started becoming more popular and used more broadly. These are the patients who are spontaneously breathing. So that number doesn't really change. But we can see these patients who we used to not use CPAP at all, and once we started using CPAP, the way that we used it became more and more frequent. So we used it almost all of our patients now, whereas intubated patients, that number of patients has dropped significantly, and obviously it was when we started using CPAP. What did we learn? We learned that we can manage these kids really well on CPAP. And that was good news for cost of stay and length of stay, because those kids on CPAP had a decreased hospital stay, but they also had a decreased ventilator. They were on respiratory support a lot shorter than those patients who were intubated. So what does this tell us? This tells us very clearly that when we can manage a patient non-invasively, we need to do it. This was a super interesting study as well. This was a very large study, over 6,000 patients who were admitted to the PICU. And this was multi-center study. So these patients were admitted to the PICU, and they were either assigned to be on a high-flow cannula as their initial respiratory support, or on non-invasive positive pressure ventilation as their respiratory support. And they were looking at who got intubated. And what they found was that only 11% of the kids who were initiated on high-flow cannula got intubated, whereas 20% of the kids who were initiated on NIV were intubated. Now, when I first looked at that, I said, well, of course that makes sense. The kids on NIV were probably sicker to begin with. But this study specifically leveled that playing field by correcting for the disease process, whether it was bronchiolitis or how severe the disease was. It also corrected for age, weight, and gender. So it leveled the playing field so we can really trust this data. And in the discussion panel of this study, what they talked about was why this happened. So why did the kids who were on high flow get intubated less frequently? Well, we know we're learning more and more about high flow, which is really great. I think that if any of you guys practiced through COVID, you probably used a lot of high flow therapy on your patients because it washes out the CO2. Similar to non-invasive ventilation, it's going to wash out that CO2 in the upper airways. High flow can generate a certain level of positive pressure in the lungs. We're not quite sure how much, but it does create some, so it does help in the work of breathing. The other big difference between high flow and non-invasive positive pressure is that it's so much more well tolerated by the patients. Their kids aren't trying to knock their mask off their face. I had one patient tell me, it feels like you're trying to smother me into breathing. We can imagine how uncomfortable that is until they learn how to let it breathe for them. So because it's a more comfortable interface, they're not trying to knock it off, you're not having to use as much sedation, there's also less gastric insufflation, so their belly's not blowing up and fighting against the diaphragm when the diaphragm's trying to take a breath. There's also some vascular preload in issues that you have when you're doing positive pressure ventilation. So because of this, mostly because of the comfort of high flow and that it's well tolerated, these kids didn't end up getting sick or intubated. So let's talk about ARDS in the PICU. ARDS is a severe inflammatory process, same thing in adults, that causes diffuse alveolar damage. What happens when the alveolar level is damaged? We start getting a ventilation perfusion mismatch, which we'll get into ventilation perfusion mismatch in a little bit. It's going to lead to severe hypoxemia and poor lung compliance. It's going to lead to respiratory acidosis. Can be from a couple of different things. ARDS patients at risk for ARDS come from a different area. Some of them have pulmonary infections like the RSVs, your rhinoviruses, bacterial infections such as pneumonia. It can also happen after traumas. So pulmonary contusions and the associated inflammation that results from that and infections are more at risk when you have a traumatic injury as well. Aspiration, so a lot of neuromuscular patients might have some aspirations and that direct lung injury can lead to ARDS. We've also got non-systemic inflammation, so maybe it's transfusion related. Those patients who are oncology patients who are getting transfusions, that can have some risks and that can be a non-direct injury, lung injury, patients who are septic as well. Why are we so concerned about ARDS in our pediatric population? ARDS is not that common. It only happens in just over 2% of the pediatric population. But of those patients who do get ARDS, 33% of them don't survive. So it's super significant, trying to avoid it in all of our patient populations, trying to minimize lung injury in our patient populations, at least lung injury that we give them. They might come in with lung injury, but we're going to try to not make it worse. Patients, all of PICU deaths, 30% of all PICU deaths are patients with ARDS. So it's pretty significant. And there are some recommendations. The Pediatric Acute Lung Injury Consensus Conference does make some recommendations on how to manage kids with ARDS. One of the things that this conference does say is we don't know a whole lot about it, and a lot of these recommendations are based on adult studies, and that we do need to study more in the pediatric population. So what we do know is based on what we know about lung physiology, keeping your tidal volumes lower, so lower tidal volumes with a higher respiratory rate, thinking about taking your PEEP up so that your opening pressure is less and that you don't have that shear damaging pressure. Keeping a close eye on your plateau pressures. Most of the data, most of the literature, everything you hear says right around 28 to 30 is when you start to get concerned about their plateau pressures. You want to allow some permissive hypoxemia and some permissive hypercapnia, but you want to keep a real close eye on your oxygenation and your CO2 level so that you're not going too far out of range. If your plateau pressures do get higher, you need to think about lung protective strategies such as the oscillator. One of the things that this pediatric conference does say is that continuously monitoring your CO2 is recommended to keep a close eye on what's going on with these patients, and I think that makes a lot of sense to all of us. We really want to know what's happening. So when it comes to those patients with asthma, there's a lot of interventions we do when these patients come in. We give them bronchodilators, we give them steroids, sometimes we try a little bit of Heliox on them. And how do we assess whether or not these treatments are working? A lot of times, of course, we're looking at their oxygenation status, but when it comes to their ventilation status, if they're not intubated and we can't get a good end-tidal CO2, what are we looking at? We're looking at their work of breathing, how comfortable they are, and their other vital signs as well. So if you can continuously monitor their CO2, that's really going to help guide you to know whether or not your treatments are being successful. There are some lung protective strategies when you're dealing with a patient with asthma. things like keeping that tidal volume low. You know, when we're trying to blow off CO2, we all know you want to go up on your tidal volume. You want to go up on your minute ventilation, right? But we also know patients with severe lung disease, things like asthma and COPD, sometimes it's counterintuitive and you have to go down on their respiratory rate so that they have a longer time to exhale to get rid of their CO2 because they're struggling to get rid of their CO2. Well, how do you know? How do you know if you need to go up on the rate or down on the rate? If you can continuously monitor your CO2, that's really going to help guide you so that you'll know whether to go up or down. There's a couple of recommendations here, you know, increasing your inspiratory flow, decreasing your I time to give that longer exhalation time. And then again, using high frequency techniques to help with those patients who have high peak pressures. Now, I talked a little bit about those patients who have asthma and how to manage them, and when you're trying to keep them from being intubated, how we're using these bronchodilators, steroids, and other drugs to help relax their airways. Using continuous CO2 monitoring can really guide that. Sometimes we'll use Heliox, which is a lighter gas, and so the patients can move it in and out of their lungs better. But Heliox is one of those things where if it's going to work, you're going to know within 15 or 20 minutes. So you want to try it for 15 or 20 minutes to see if that helps the patient's work of breathing, if it helps their oxygenation status, and if you can see their CO2 status to see if it helps their ventilation status. The bottom line is you want to give them enough pressure so that you're blowing off the right amount of CO2, but not so much pressure that you're just messing up their lungs. You don't want to cause the volutrauma. You don't want to cause the overdistension. You don't want to cause the barotrauma to their lungs. But you also want to give them enough support that they're not collapsing down. Keeping that safe window is where you need to really watch your CO2, so you know where that safe window is, where you can allow for some permissive hypercapnia without giving them too much support or not enough support. So really maximizing your ventilation strategies. So let's talk about monitoring patients who are on non-invasive ventilation, so the ones who we are not using end-tidal on. A lot of times we say, well, oxygenation is a pretty good reflection of ventilation. Sometimes it is. Sometimes it goes hand in hand. Sometimes it doesn't. We've got a study here that looked at, it was a small study, only 50 kids, but they were on long-term non-invasive ventilation. And what they found was that 42% of these kids had increased CO2 values with keeping their SpO2 values still above 90, so relatively normal. So what this study told us was that the oxygenation does not reflect the ventilation, and we know that's true with a lot of cases. A lot of times it goes hand in hand, but a lot of times it does not. So, all right, Margie, we get it. We should be looking at the CO2 a little more closely. Yeah, we should. How are we looking at it? A couple of different ways. We are looking at the blood gas. Of course, that's going to be your gold standard. That's always going to be the gold standard. But it's just a point-in-time measurement, so we'll talk about that in a little bit. We also have end-tidal CO2, which is great. I mean, when you think about it, it's really impressive. The CO2 in your exhaled breath is an accurate representation of your CO2 in your blood. But only as long as you have healthy lungs and you don't have a ventilation perfusion mismatch. And I promise you, you will very clearly understand that whole mechanism here in a minute. Then we have the third way to get your CO2, which is transcutaneous. It picks up the CO2 that's diffusing across your skin, so you're not worried about your airway at all. You don't have to be intubated to get an accurate value. Now, because it's picking up the CO2 that's diffusing across the skin, you're going to want to have good perfusion to that sample site. So that's the big thing with transcutaneous. If you have a patient who's septic or very, very acidotic or very cold, if they, for some reason, have some vascular shutdown, it's going to be a little bit more difficult to get an accurate value. So let's talk about blood gases. Now, when blood gases are great, they're measuring the blood directly, so you know exactly what the blood CO2 is. Also, you know what the pH is, and you know what the PaO2 is, which is important in a lot of patients. Especially in patients with ARDS, you need to know what their oxygen level is, and it's nice to have their PaO2. But it's just a spot check, and the potential for infection is there. And so what I mean by spot check is that here's an overnight trend of a patient, and I don't I don't have my slide builds, but this first one, the blue dots, are going to be your blood gases. So this was a patient with hypoventilation syndrome. This was a sleep study, actually. So we did 4 blood gases throughout the night. The first 2 gases, the first one's like in the high 30s, which is good. That's probably what all of our CO2 level is, hopefully. Then in the night, it jumps up to the mid-40s. In the deep night, when he's in deep sleep, it jumps up to the 60s and then back down in the morning. Fortunately, we have the transcutaneous. So if you're just looking at the blood gases, it doesn't look too bad, right? So we do have the transcutaneous values, and you see as soon as this patient fell asleep, that CO2 shot way up. And then it dipped back down when they woke the patient up to get a blood gas, right? And then it goes back up again, and fortunately they were able to sneak in and get a blood gas when the CO2 was high. The point of this is that when you're looking at the blood gases on this patient, it doesn't look too bad. It's just a point in time. But when you have continuous visibility, it shows a completely different picture. When I was driving here yesterday, my flight landed a little bit late, so it was dark when I was driving here, and I'm driving here in these windy roads, which you guys are all familiar with those roads, I'm sure. But I would have my headlights on, but as soon as there was no vehicles, I wanted my bright lights on because I really wanted more visibility to what's going on. And I think about that, and I think about how if you're just going on your blood gases, that's like driving on these windy roads without any headlights at all. You don't know what's coming up. You don't know unless you've got your headlights on. So turning on your headlights gives you continuous visibility and a lot clearer picture. I think that's what transcutaneous CO2 monitoring is like. It's having that full picture lets you know where these curves are, not just a snapshot. Oh, there's a curve. Oh, why am I in a ditch? You know. This is another graph. This is a neonatal patient. There's a blood gas here. When they took this blood gas on this neonatal patient, he's doing great. It's in the mid-40s. That's exactly where we want our babies to be. But about 30 minutes after that blood gas was taken, we see from the continuous transcutaneous value that it shot up. Now, if you've ever worked in a NICU, what we do is we do blood gases. If they're good, we're gonna let it ride. We don't want to stick these kids. We don't want to draw blood from these kids. That's too much blood drawn from them. They need a transfusion. We don't want to risk the infections, and the pain and stimulation. We don't want that for anybody. But so after this blood gas, about 30 minutes later, the CO2 shot up. Well, you wouldn't have known it. The clinicians wouldn't have known it if they didn't have visibility to the CO2. They would have found out in 6 or 8 hours when they did another blood gas, or if the kids started decompensating in general. So having continuous visibility to this patient's CO2 was very helpful. When you see a patient jump off their CO2 from their baseline, you can go in and intervene. Same thing when their FiO2 requirement goes up. What do we do when their FiO2 requirement goes up? Well, we go in, we make sure that their airway's open, we suction them if they need to be suctioned, maybe we reposition them, maybe they hate laying on their left side, and we move them over to their right side to get that FiO2 requirement to come back down. Same thing with the CO2. If you've got continuous visibility of the CO2 and there's an acute change, you can go in there and figure out what's wrong with your patient, see if we can get that CO2 to go back down. If you're just going on blood gases, you're going to react by making a vent change, then you're going to react to that vent change by drawing a blood gas, and then you're going to react to that blood gas by making another vent change. So that means you're treating that patient reactively versus proactively. When you have continuous visibility, you can be proactive. You can say, oh, that CO2 went up. That's not normal. I'm going to go in there and figure out what's wrong. Go in there, figure out what's wrong. And I love that. As a respiratory therapist, it's like a superpower. Oh, I'm going to go in there and get that CO2 back down before we have to do another blood gas or a vent change. Sometimes they've changed. Sometimes their conditions change. Their lungs have gotten worse, and so you do need to go do a vent change. But you want to be able to get in there and give it a shot first before you lean on vent changes. The other problem with blood gases, of course, when you're drawing blood, there is going to be the risk of infection, whether you're doing an arterial stick or a capillary stick on a patient or even a venous stick. That risk of infection is there. Pain is always there. Even if a patient has a central line, if you're lucky enough to have a central line, the risk of infection is very high. Central line associated bloodstream infections, they're the major source of hospital-acquired infection in the pediatric ICU and in neonatal ICUs. And they are associated with a significantly longer length of stay and they do increase morbidity and mortality, and of course, cost of stay. We always have to throw cost of stay in there in case we've got any C-suite sneaking in here listening to us. So, limitations of ABG, although they are the gold standard, they always, I don't know if they always will be, but they are just a point-in-time measurement, which we would all agree that we would want continuous visibility over anything versus a point-in-time visibility. They do risk infection, and they do lead to reactive management of the vent versus proactive management of ventilators. Okay, capnography, end-tidal CO2, which seems like more of us are familiar with end-tidal CO2 technology. A lot of ventilators have it built right in, which is nice. I know it can be frustrating because it does add a little bit of dead space, which you're probably not so concerned about in the NICU, in the PICU in adults, but you are concerned about that in the NICU. It also gets gunked up a lot of times with secretions or humidity. The other big thing about capnography is that it underestimates patients who have a VQ mismatch, which is a high portion of patients with ARDS, whether it's in a PICU or whether it's in adults. And patients with pneumonia, they're all going to have a VQ mismatch. And so the end-tidal CO2 is going to underestimate that. So let's get into VQ mismatch. What is it and who has it? It's when either perfusion to the alveoli or airflow to the alveoli, or a little bit of both, is restricted or blocked. So hypercapnic respiratory failure causes a VQ mismatch. It results in an increased PaCO2 of above 50. Other lung issues that cause VQ mismatch are going to be things that are blocking the air from getting in. So your pneumonias, your restrictive lung diseases, your asthmas, your COPD, all of these things, when there's a restriction of airflow, you're not getting enough air to the alveoli to be absorbed into the bloodstream. Cardiac issues can cause decreased blood flow, decreased perfusion to the lungs, so that you don't have that alveolar gas exchange. I've got some graphics here so we can see VQ mismatch in action. Now, a normal breath, when we breathe in, everybody take a nice deep breath in. When we breathe in, we're breathing oxygen into our lungs. It's going to the alveolar level, and it's diffusing into the bloodstream because our lungs are getting some pulmonary perfusion, right? So we're breathing that oxygen in, it's going into the blood, CO2 is following a reverse course, it's coming from our blood, and when we exhale, hopefully y'all exhaled without me prompting you to, when you exhaled, you released that CO2. So in normal lungs, what you exhale is going to represent what's in your blood, which again, that's pretty cool, right? How many times are we dealing with normal lungs? If everybody had normal lungs, we'd all have to go find another job. Did y'all ever think about where you'd work if you weren't a respiratory therapist? How many of y'all think you'd still stay in healthcare? How many of y'all would go work at Starbucks? Just for the benefits alone, right? Like free coffee. So, okay, back to the fact that not everybody has healthy lungs. So if you've got a reduced flow, and that these gray lines indicate a reduced flow, so you're breathing the oxygen in, but it can't make it, you've got reduced flow, so it's not making it all the way into your alveoli to be exchanged into the bloodstream, it's exhaled instead. In the same way, the CO2 is staying in your bloodstream because it can't get out of the lungs to be exhaled. So what's going to happen here? Your exhaled CO2 is not going to match your blood CO2. It's going to be lower because the CO2 can't get out. Even though it's higher in the blood, you're not exhaling it properly to be measured properly. Same thing if you have restricted blood flow. So a lot of times positive pressure ventilation is going to compress that pulmonary capillary bed so you get restricted blood flow, or cardiac disease, pulmonary hypertension, etc. If you've got a reduced blood flow to your alveoli, even if you have super healthy lungs, the oxygen's not going to be able to get in because of that reduced blood flow, CO2's not going to be able to get out because of that reduced blood flow, and then your end-tidal CO2 measurement is not going to be accurate. So in all cases of ventilation perfusion mismatch, whether they're from airflow or from blood flow issues, or very, very likely both, your end-tidal CO2 measurement is going to be underestimated It's going to be an underestimation of your PaCO2. I saw this so very clearly in an LTAC about a month and a half ago. I was in Boston with one of my colleagues, and we went to this LTAC. They were interested in transcutaneous CO2 technology. And as we're talking to them, they said, one of the therapists comes out and was like, oh my gosh, I have a patient that this might be really good for right now. And we're like, tell us everything. This was a 35-year-old man who was vent dependent his whole life. He was not responsive to anything and hadn't been. And according to his end-tidal CO2, his CO2 was pretty normal, but he was riding the vent. And they were very concerned, and they were going to do a blood gas. So they were looking for the one therapist who was the best at blood gases, because this guy was a hard stick. He was very edematous. He was contracted. He was a hard stick. So they get out that one person who has the best chance of sticking him and doing it right. But before she did it, they said, but we want to see what his transcutaneous CO2 is. So we go in there. They happen to actually have a monitor at another part of the facility. So we got their monitor. We put it on the patient. His end-tidal was reading 50. And the transcutaneous value is climbing and climbing and climbing, and it finally stabilizes at 80. And so we're like, wow, that's a big difference, 30-point difference, right? That's significant. Which one is right? So we were talking to the therapist, and the therapists were kind of basing it on what they thought was going on with the patients. And the therapist who had the patient said, I think it's 80. And the other therapist said, I think it's closer to 50. This guy had pneumonia, by the way, and when they saw that 80 on the transcutaneous, they went ahead and bumped up his respiratory rate. I think it was on 12, and they bumped it up to 14. They'd also noticed that his tidal volumes were trending lower. So she gets the blood gas, and we all hold our breath a little bit, and it comes back 80, spot on with the transcutaneous value. That his ventilation perfusion mismatch was so great, it was 30 points off, because he had pneumonia, because he had chronic lung disease from being intubated his whole entire life. And I tell you, the girl who did the blood gas, she pulled me aside later and she said, man, I thought for sure your monitor was way off, but you guys were spot on. They were so impressed. And it was exciting to know that they can now trust that transcutaneous value, and they can make vent changes and get his CO2 back down to where they want it without having to stick him a whole bunch of times, because he didn't have access, and he was a hard stick. So that poor one girl would have to come in the middle of the night to do a blood gas if they needed one. Do you guys have any thoughts on ventilation perfusion mismatch, or anything you want me to clarify on it? I know that when it comes to this transcutaneous CO2 monitoring, that's really the big difference between us and end-tidal monitoring. If y'all have any questions at all, anytime, just interrupt me. Okay, so when we're talking about end-tidal CO2 management and non-invasive patient, the other thing that happens is it underestimates patients who are not intubated, but that they're on a respiratory assist device, because when you're measuring your CO2 at the airway, you've also got the flow from the respiratory assist device and any leaks, if there's any mask leaks around it. So that's going to mix it as well, and you're going to have an underestimation of your CO2. So across the board, end-tidal, it's great when you have an intubated patient who has relatively healthy lungs, and a lot of times you can use it to trend even if the lungs aren't healthy. But it's got the limitations if they're extremely unhealthy lungs, and also if the patient's not intubated. And now that we're managing so many more patients non-invasively, which is a good thing, we need a better alternative to monitoring their CO2. So now I'm going to talk about transcutaneous CO2 monitoring. Of course, it's going to be accurate despite any ventilation perfusion mismatch, because we're not measuring at the airway, we're measuring what's diffusing across the skin. I'm going to tell you how it works. If you guys, are any of y'all familiar with transcutaneous CO2 monitoring? Does anybody use it? Just a few people, and then some of y'all are familiar with it? Okay. Well, the way that it works is we use a little attachment ring to put the sensor, attach the sensor to the skin. So you put the little sticker on the patient. I had some students one time call it a barnacle, which I thought was cute. I was on Virginia Beach, and that made sense because they were nautical people. So you put the barnacle on, and you put a drop of gel inside of it, and then you put the sensor into that little ring, and that's going to hold the sensor in place. You want to use a drop of gel in there because what you're doing is you're creating a measurement chamber for your CO2, and you want it to be airtight. You don't want air getting into it. Similar to when you do a blood gas, you don't want any air bubbles because that's going to change your oxygen level and your CO2 level. When you're measuring CO2, when you're taking that sample, you want that to be airtight as well. So we put that on there, CO2 diffuses across the skin, it goes into a sensor where a reaction takes place, and then based on that reaction, the sensor has an algorithm and it'll give you an estimate of your arterial CO2. So that's where we're getting our sample. And because perfusion is so important to get a good sample, it does warm it a little bit. The sensor temperature, depending on your patient population, it's usually 41 or 42 degrees. It's going to warm that site, which encourages blood flow to the site. It arterializes the capillaries, so it makes that capillary gas look a little bit closer to an arterial gas. And that also, the heat also helps CO2 diffuse across the skin so that it can go into the sensor where the reaction can take place. So perfusion to that site is the number one thing to think about when you're thinking about accuracy. So if you do use this technology and you find it spotty or inaccurate, think about perfusion to your site. So we want to have it someplace on the patient's core. Their forehead is a great place, anywhere on their upper chest. Their torso is a really great place as well, but the thing to consider is that any pressure on that sensor, you know, if you push on your nail bed, it turns white because you're pushing capillary flow away from your nail bed. So if you're pushing on the sensor, you're pushing blood flow away from your sample site, and that's going to make it inaccurate. So if you use this technology and you find that experience, that's something to consider. That was, when I first started using this technology, I didn't know that, and so I was working in a NICU and I would swaddle the kid real tight, you know, make sure that sensor was really up against the skin, and I was wondering why, wondering why my CO2 was off by 15 points. So it's going to allow you to have visibility to your ventilation status, whereas SpO2 monitoring alone does not. It gives you that continuous real-time measurement. You've got your headlights on compared to the ABG, which you're just turning your headlights on every once in a while. And it's going to, patients, it overcomes the limitations of in-tidal monitoring because we don't have to worry about that ventilation perfusion mismatch, and we also don't have to worry about what's going on at the airway. I talked about that. We're good with that. Y'all are good with that, right? Okay. I wanted to get into one of the best things about transcutaneous CO2 monitoring, and that it does allow you to have proactive maintenance of your patients rather than reactive maintenance of your patients. So there's this study, it was a pediatric ICU, and they wanted to see if transcutaneous was a viable option to use on their patients who were on the oscillator. So first thing, because they don't want to do blood gases on these kids, and they also couldn't use in-tidal on these kids. So the first thing they wanted to do was make sure that it was accurate. They had 100 samples, 100 blood gas and transcutaneous samples to measure the accuracy, and what they found was that an R-squared value of 0.96, which for those of us who aren't statisticians is very, very good. That means almost all of them were spot on. So they said, okay, wow, we can really trust this on our patients and our PICU patients on the oscillator. And based on that accuracy, what they were able to find is that they were able to manage these kids on the oscillator so much more closely. Now, when we go from conventional ventilation to the oscillator, we're guessing at the settings. How you manage an oscillator, how you decide how much ventilation to give them, you look at their chest and see how much their chest wiggle is. It's so subjective. But if you can get an objective value in there, the actual CO2 value in there, you can know, are my settings right? Do I need to increase? Do I need to decrease? Can't tell you how many times we get a baby in the NICU, they're super sick, they go from conventional to oscillator, you get the blood gas, their CO2 is 24. Well, you don't want that. But if you've got continuous visibility of the CO2, you can see it dropping, dropping, dropping. Hey, it's 50. Hey, it's 40. Let's pull back on those settings, figure out where it levels out before having to do a bunch of blood gases and then chasing your tail with the blood gases. So this team that was specifically looking at transcutaneous use in patients who are on the oscillator really did appreciate having that real-time value so that they can manage these patients more tightly. And they concluded that it was a viable option, an alternative to doing a bunch of blood gases. Places aren't replacing their blood gases with this, but they're getting clearer visibility to the full status. So a lot of times they are decreasing the number of blood gases, which is the goal. Some places do trust it to where they're doing blood gases every other day. But this team did find that it was very helpful, and they were able to, again, treat those patients proactively versus reactively. Accuracy is super important. We did see that with this patient population, they did find very accurate values. There's some accuracy data across a couple of different patient populations. These were in children less than 2 years old, and they found that the correlation was very good. The R value on that was 0.7, which is great correlation. When they looked at how many times the transcutaneous value fell within the limits agreement with the blood gases, it was very good in patients who were, this top one was patients who were less than 18 years old, and they found very good correlation there. And then again on mechanically ventilated infants who were 27 weeks or older, they found great correlation. So across the board, when used properly, so when you're aware, this is where I'm getting my CO2 sample. I'm making sure that it's well perfused. I'm making sure that there's no pressure on it. I'm making sure that I've made an airtight chamber by using gel. When it's used properly, your accuracy is very good, and you can really trust it to enhance our clinical view of what's going on. If you have used this technology in the past, like let's say 15 years ago, the thing that you might remember is that the heat from the sensor would cause some redness on the patient's skin and would have to be moved very frequently. Because now digital technology is using lower sensor temperatures, we don't see that. What that means is that you can leave it in that same spot for 8, sometimes even 12 hours, monitoring continuously for 8 to 12 hours without needing to change a spot. The sensor itself does need to be calibrated on a regular basis. It's like a blood gas machine, so it is recommended to calibrate it every 8 hours. You take it off, assess the site, make sure the site looks good. If the site looks good, you can go back to that same site for up to 24 hours. In between those calibrations, you can just return to that same site. We've got a couple of skin integrity studies here that looked at pediatric and neonatal patients, and they monitored for 12 hours without any detectable skin harm. More and more, we are seeing guidelines coming out from the AARC that states that transcutaneous monitoring should be used when you are mechanically ventilating a patient, and that you can rely on it to guide your mechanical ventilation. It's indicated on patients who are on non-invasive ventilation, patients who are on high-flow cannula, patients who are not intubated. And they do say that weaning and extubation decisions can be made based on your transcutaneous measurements alone. Now, when I tell you that, I would want you to use the monitor for yourself, learn how to trust the monitor, learn how to use it properly. And when you do that over time, you will say, okay, actually we can really trust this. And I would go ahead and say that as a respiratory therapist, you could probably look at your patient and guess what the CO2 is, and you'd probably be within 5 points if you've been practicing. That learning curve would go up the longer you practice, the more accurate you can get. Or how many times do you guess the ventilator settings? Okay, I think this patient's going to need this, and you get that first blood gas back, and you're all excited because you get it right. So our clinical assessment is really good, and we are good judgments of what a patient's CO2 is. So between our clinical judgment, between having that objective value of the transcutaneous measurement, we can hopefully decrease our blood gas draws, speed up our weaning process, speed up our extubation process, hopefully not even intubate in the first place, thereby decreasing the patient's overall length of stay, their mechanical ventilation stays, exposing them to the risk of pneumonia because they're mechanically intubated. In summary, we know that, I don't know why this just got really loud. It's okay. In summary, we know that we are using non-invasive ventilation more across all patient populations, not just the PICU and the NICU, but in the adult populations as well, and that we need to monitor patient CO2. It really, we should start considering it like a vital sign. It used to be SpO2 wasn't a vital sign, but now we do consider SpO2 a vital sign. And CO2 really should be considered a vital sign as well. So we can monitor it. We should monitor it. We should be watching it very, very closely. Arterial blood gases are just a point-in-time measurement. We want more visibility to the patient's respiratory status than just a blood gas. And transcutaneous monitoring does help overcome the limitations of in-tidal monitoring and blood gases alone to give you continuous visibility. You can see that it would be well tolerated by the patient because it is on their skin, not in their nose. And just the added clinical data really helps us practice more accurately as respiratory therapists. So I hope that you found that helpful. I hope that you have questions. Again, I do want to remind you that I do work for one of the companies, so if you do have questions, I'm going to refer to my experience with the one technology that I have bedside experience with, and the technology that I know very, very closely, that's very near and dear to my heart.